Thank you very much. I'm Dr. Slocum, and our presentation today is on narrative medicine and communication therapy for the communication disorder of functional seizures, also known as psychogenic non-epileptic seizures. So if we can forward the presentation, that will be helpful. I will continue. Let me just say that narrative medicine, first of all, for those of you who may not be familiar with it, draws out the patient's narrative of illness or injury in the context of the patient's entire life story. It invites the patient to put significant experiences into words, allowing dialogue, unstated or silenced concerns can be given voice and new insights discovered. Narrative medicine may also include written responses by patients to writing prompts, discussion in journal workshop groups, and discussion of patient writings with the narrative medicine provider. Narrative medicine is engaged through provider-patient dyadic relationship. That is to say, it is not scripted, it's not just an interview or a series of questions, but rather an opportunity for the two, giving and receiving, the one who tells and the one who listens, to engage dynamically. It's not predictable. Unexpected turns may come up. In my own practice, I've had patients whom I expected to talk about one topic with great focus, like say a patient receiving chemotherapy for cancer, and it turns out they're not concerned to talk about that at all, but dealing with issues of grief, say from a recent loss. So narrative medicine is flexible and dynamic. It goes to the patient's concern, which may or may not be the provider's concern at that moment. So again, it's patient-centered, open-ended, and unscripted. The patient in narrative medicine introduces new perspectives in history and issues that they have brought to the discussion. It's distinguishable from cognitive behavioral therapy, CBT, and related therapies by its focus on drawing out and integrating the patient's story for wellness, not confronting, correcting patients' unhelpful patterns of thought and behavior. It's not confrontational, although suggestions may certainly be offered as needed and as appropriate. The typical basic questions underlying an initial session in narrative medicine and are available always to go back to as the discussion may continue over time and multiple sessions. The four basic questions: what brings you here? What helps you the most? Do you see anything differently after the experience is mentioned, whether that be illness or injury? And what comes next? What comes next for the patient, which taps into their hope for the future, their orientation, their goals. All of these factors may be raised by the patient. The process itself helps the patient to renegotiate their own sense of self, their identity, self-awareness in the context of changing circumstances due to the illness or accident, injury, whatever has brought them to care. The patient may discover new insights in retelling the story. They may be surprised by their own answers at times. It may be an occasion of discovery for the patient as well. Each retelling of the story may be a new version, saying you can't tell the same story twice. The details, the emphases, the points of focus will change over time as the patient recalls and works through a particular story. Narrative medicine sessions can help patients face and work through what can be understood as the biographical disruption of illness or injury. This is drawing on Lassignol's writing that the illness itself, the condition itself, disrupts the patient's sense of independence, competency, autonomy, sense of orientation to the future. Forming a story about life events can be associated with improved physical or mental health across a variety of populations, and studies bear this out. Painful events not structured to narrative may contribute to narrative thoughts and indeed lead to rumination, just going over and over and over so that constructing stories and talking them through can help the patient to move past rumination and conscious thought, repetitive thought about troubling experiences. Pennebaker and Seagal are an important source in this regard, leading to important advice. If a patient is having trouble sleeping, for instance, because they are caught up in ruminative thoughts, thinking over and over about something, urging the patient to write it down, put it into words, say, I've said everything I need to say about that at this moment, may be helpful for the patient as they seek to rest and move forward. So that's just a very basic introduction to narrative medicine, which can be helpful for this second major phase in my presentation, discussing functional seizure or psychogenic non-epileptic seizure as a communication disorder. These two terms are both describing the same condition, let me say. It's just different people use different terms to describe it. And the episodes of functional seizure, also known as spells, resemble epileptic seizures in some ways, although this can be ruled out by video EEG, which is the gold standard for distinguishing a non-epileptic seizure from an epileptic seizure. But the patient with functional seizure may exhibit involuntary paroxysmal activity. The spells themselves may be described by the patient in catastrophic terms. Oftentimes they'll say, I felt like I was dying. It may be dramatic. Frequently, the event may take place in a public context, provider examining rooms, waiting rooms, providers who will be engaging patients with this condition. It's helpful to have a plan in advance what to do if an episode of this nature were to occur. And these may often be misdiagnosed and mistreated as epileptic seizures. And in that case, treatment may actually cause harm. In an emergency room, let's say, where the emergency room or department provider assumes that the condition is caused by epilepsy, may administer an AED, an anti-epileptic drug, which again, if this is not an epileptic seizure, that may prove quite unhelpful and make the patient worse instead of better. In one study, a typical epilepsy center, 20 to 40% of patients diagnosed with epileptic seizures not responding to drugs were misdiagnosed, and many of these had functional seizure or other forms of syncope or parasomnias. And in some cases, 7 or more years have been known to intervene between the first presentation of symptoms of functional seizure and an accurate diagnosis. And that's, to me, horrifying, and all the things that can go wrong for the patient in their lives as a result of these episodes going misdiagnosed, undiagnosed, untreated. Functional seizure, PNES, may be described as an orphan disorder. It sort of falls between two stools with no one discipline taking full responsibility for it. It's not exactly neurological, but it is in a way. It's not exactly psychiatric, but it is in a way. My position is a team approach, an interdisciplinary approach is the most effective way to respond. Functional seizure has been described as a communication disorder, not a language disorder, not an aphasia, but a disorder of expression. This by Dr. LaFrance, and also by Jung and others, pathological somatic expression of stress, a communication disorder where the patient's body has taken on a communication of its own as the patient cannot or will not communicate directly about what is an overwhelming topic, an unspeakable subject. Family or social expectations may be part of the reason why the patient cannot or will not speak about these things. A kind of code of silence, isolation, stigma. The patient may have been told in a family context, we don't talk about such things. the patient's condition may go back to a traumatic event in which the patient was actively threatened or warned about bad consequences if they mentioned to anybody what had happened. They may be afraid for their own welfare, for the welfare of loved ones or others. So all of these could be factors in terms of the silence. It may just be that the patient is embarrassed or unwilling to try to talk about these matters. They say, I don't want to dwell on that. I've moved on from it, when of course they have not. And until they face the situation, the condition will not get better and is likely to get worse. In some cases, patients have been suspected of malingering or faking symptoms, have been stigmatized by their own healthcare providers, coworkers, family members, and others in society. I remember one case where a patient who came to speak with me reported being, in a sense, verbally attacked by her medical provider, told, you can't do this here. Meaning she was having a psychogenic functional event in the provider's office, and he was attacking her as if she was choosing to do so or disrupting the peace of his office. Obviously, that was inappropriate. She wasn't doing this by choice, certainly. In any case, some physicians have responded inappropriately. Functional seizures may serve a useful and protective function of a sorts, allowing the patient to be distracted from or escape temporarily from an overwhelming and unspeakable trauma or stress, but at a terrible cost for the patient in terms of the overall disruption caused in their life by this situation, by this condition. So functional seizure may reflect the repression of unacceptable emotion or be a disassociation from a distressing experience. The symptoms may serve as a warning signal to the patient and provider concerning present stress. I say there is perhaps a silver lining in that for a patient who is a somaticizer, if that hasn't been going on recently and starts to happen, it's a fair question. Well, what's changed? What's different now? Frequently, something will have happened, whether a new source of stress or a new reminder of a previous stress, something that brings this out, something that triggers this. So the symptom may be a warning sign, kind of like for a driver, the light on the dashboard that warns that the engine is overheating or a tire is going flat. Well, this can be a kind of physical, visible warning to the patient, to the provider. Something has changed, something is going on, and the patient may currently be trying to hold an unbearable pain inside, but unsuccessfully. Functional seizure may result from exposure to a traumatic experience, which could be sexual assault, it could be a physical or emotional abuse, or other overwhelming event. There's also what's been referred to as developmental PNES or functional seizure, in which the patient faces an upcoming life milestone, whether that be leaving home or loss of a job or loss of loved one, which may itself be overwhelming, or the threat of the approach of that event may be seen, perceived, experienced as overwhelming. I offer one case study from a patient I saw that gives a very clear, I believe, presentation of this process, and also how narrative medicine, the talking through with the patient process, can be clinically helpful. So in this case study, the patient had been sexually abused as a very young child for some years by a much older relative, had been warned to keep silent, warned not to tell. The patient had seemed happy but was afraid. Onset of functional seizure came when she was in her 20s. With these events, she thought she was dying. And she had as many as 10 of these episodes in one day. She required or felt she required frequent visits to the emergency room. These visits didn't tend to go well. The somatic symptoms that she reported proved to be inconclusive, did not lead to successful diagnosis of physiological conditions causing her symptoms, and she would have additional symptoms in the future, additional visits. This went on for some time. Her first functional seizure episode took place in a shower when she was at home. And as she later, in the context of narrative medicine sessions, began to unfold her story of abuse, she revealed that she was first approached by her abuser in a home bathroom. Previously, unexplained anxiety had been triggered in a situation for her where she had a medical test. While waiting for this test, I believe like an x-ray, was on her back in a dark room. There was the sound of a closing door, and then she had functional seizure. All of those events were relatable to her past abuse history, the being on her back, being in the dark, hearing a closing door. But her symptoms diminished and her affect brightened as the narrative medicine sessions continued, and the symptoms that could indicate overwhelming stress became more manageable. She had fewer emergency department visits and also felt that she had a strategy, had a way to cope when they did come on. So she had a perspective that maybe this wasn't the end of the world for her, but rather something that could be managed. The patient constructed a written or oral story about personal trauma and overwhelming distress. In this way, can discover a narrative antidote to the communication disorder of functional seizure. Discover hope, putting the unspeakable into words, finding it is possible to face, to work through, to overcome. Some patients with functional seizure tell the stories of their traumas and overwhelming experiences for the first time during narrative medicine sessions. Others, it may require an ongoing series of these discussions. The patient in the story that I mentioned, the case study that I mentioned, had a sort of turning point several sessions in. At first, she had said, well, this was a part of my history, but I believe I've worked it through. And only later in the process came to say, well, I believe I haven't worked it through. And that was a turning point in when she was willing to delve more deeply into a very traumatic situation that continued to cause her harm. Patients with this condition may face a difficult history and unhelpful attitudes that interfered with their healing and kept them stuck. Patients' awareness of their events are psychogenic may itself prove therapeutic. One report by Baslett points to a remission rate of close to 40% at 6 to 12 months when the patients have accepted the psychogenic nature of the events that they have experienced. Patients may notice less frequent spells or less intense spells after accepting the diagnosis of functional seizure. Some patients recognize the connection between the symptoms and the trauma or stress and are surprised by the coincidence. Like they know there was time for the onset of symptoms. They know something was happening at that point, but just haven't made the connection. And I can't emphasize too strongly what a relief that can be in these moments when they find out that there is a reason, there is a cause, there is a connection that makes sense, and that the condition can be improved. Improvements in the patient's overall life situation and strategies for stress management can also relieve the patient's sense of being overwhelmed, and that itself can contribute to an improvement in the functional seizure, psychogenic non-epileptic seizure symptoms. The patients can renegotiate self-identity with new hope, new possibilities for moving forward, no longer held back so intensely from the interference that non-epileptic seizures can cause relative to work, relative to family relationships, relative to the patient's general life experience. So narrative medicine sessions encourage patients to communicate more effectively about their unspeakable traumas and to reclaim their lives from the communication disorder of functional seizure, psychogenic non-epileptic seizure. So let me thank you very much for the opportunity to present this, and I will be glad to entertain any questions.